Hi, folks. Professor Gulliford here. We are moving ahead now to chapter 5. Hope you're having a good Labor Day weekend. Most of my weekend's fun. I don't want you to think I'm working the whole weekend. I'm not. But I did want to get these lectures recorded for you. If you hear my dog Ginger in the background, she is welcoming the neighborhood dogs for the morning. Okay, we're sharing sound and video. And now we should be able to go down and find the PowerPoint on the thorax. There we go. Just that simple. The thorax, we've already talked about the airways and the lungs, and now we go to the actual chest wall, meaning the muscles and the bones of the thorax. Identify the bones, the muscles, the movement of the rib cage, the intercostal muscles, those are between the ribs, between costal ribs, the movement of the diaphragm, abdominal muscles, accessory muscles, and abnormal conditions that affect the muscles of ventilation. So you're going to learn a lot here about the thorax. One thing you need to know is that inspiration is an active process because we have to actually contract muscles to do it. Exhalation many times is passive, meaning we don't actually have to do anything. It just naturally happens. Once the lungs are full of air, then they exhale. But there are times when it's active. Let's say you're blowing out the candles on your birthday cake, or you're doing a pulmonary function test, which you will do in your clinical settings. Then it's active because you're making a conscious effort to do it harder or more rapidly. Skeletal structure, thoracic cavity, thoracic vertebrae, spine, ribs, and sternum are pretty much the main components of that. They enclose the thoracic cavity and they protect the lungs, heart, esophagus, nerves, blood vessels, all very important. The column, the spinal column, has 33 vertebrae. 7, 12, 5, 5, 4. I remember this from my own days of training. 7 cervical, 7, 5, 5, 12 thoracic, 5 lumbar, 5 sacral, and then 5 comprising the coccyx or the tailbone. So there we go, adding up to 33. The 12 thoracic vertebrae, they're the middle portion, probably the ones that we're most involved with. Um, we need to do a lot of procedures that involve the ribs and the vertebrae in the thoracic region. So except for the 11th and 12th, they have facets on the transverse processes for articulation with the tubercles of the ribs. So, thoracic cavity, 12 ribs. The first 7 ribs are the true ribs because they attach to both the vertebral column and the sternum. So they're true ribs. The other 5 ribs, they're vertebrosternal ribs. You'll never hear that term at the hospital, but we do say true ribs because they're connected both to the vertebral column and to the sternum. But the other 5 ribs are false ribs. You might also call them floating ribs because they are not, well, there we go, floating, because they are not directly attached to the vertebral column, in the back. So, true ribs and false ribs are floating ribs. All important, but there's a picture of it. Let's blow that up to a size that you can actually make sense of. And you'll see the angle of Lewis, which connects the body of the sternum to the manubrium of the sternum. You do need to know those parts of the sternum, the top part, manubrium, then the body, then the xiphoid process. Clavicles. Some of you may have managed to break a collarbone growing up. I did. And painful, but heals. It's just a bone that's in a very, what would you say, exposed location and easy to break. Jugular notch right at the very top of the manubrium. And I think that pretty well covers it. Notice that blue, that's cartilage. When you're doing CPR on a patient, you will sometimes feel or hear a crunching, a kind of crunching, you need to know that you are not breaking the patient's ribs. What you're hearing is that cartilage, which will heal after the CPR is over and the patient has recovered. But just a little heads up that when you're the one doing the chest compressions, that crunching that you might hear or feel is not breaking ribs. It's not. You're just that cartilage. Sternum, located in the center, you got the manubrium, the body. I've never heard of gladiolus at the hospital. You might as well forget about that. But sternum, manubrium, body, and xiphoid, the three main pieces of the sternum and xiphoid. Connected by cartilage that gradually ossifies into bone in adulthood. Sternum's about 17 centimeters in length. You don't really need to know that. Sternal fractures are painful. You know, everything in the chest is sensitive because nature wanted to protect the essential organs inside the chest, the lungs and the heart in particular. So, deceleration injuries can break the sternum. That would be like a motor vehicle accident, rapid stopping of a car when you hit another car, blunt chest trauma, motor vehicle accident. Most patients do recover from those, fortunately, unless there's damage to the heart or the great vessels that took place. But it takes a while, 8 to 12 weeks for your sternum to heal after it has fractured. Abnormalities of the sternum can also happen at birth, and we see a couple classic ones where the sternum is caved in. That's pectus excavatum. I think we'll probably have pictures of those. And one where the sternum is pushed out in front further than normal. That's pectus carinatum, which means bird-like. Yeah. So we will see some abnormalities of the sternum. Oh, there we go, right there. Sternal foramen or sternal cleft, that's where the sternum does not fuse properly. That's rare. We hardly ever see that. Once in a while, you actually see a patient born, infant born with the heart visible on the outside. Yeah, that can usually be corrected and must be quickly because we don't want to, leave that in such a vulnerable location. Pigeon breast, that's pectus carinatum, is keel, chest, or pectus carinatum. The sternum pushes up or protrudes, forming a bird-like pattern like you would see with a pigeon, all right, forming a ridge. But funnel chest, that's pectus excavatum, is where the chest is caved in. And you will definitely see both of these types. I've seen more funnel chest over the years than I have pigeon breast, but you'll see both. The triangular portion of the sternum, the xiphoid process, it's a landmark for CPR. We want to be above that xiphoid process. It's cartilage, and we can actually damage that. We want to be above that on the lower half of the sternum. Most methods teach a responder to place two fingers at the tip of the sternum and then position the heel of the other hand above those fingers. So it's the lower half of the sternum that we're compressing. There we go. If you guys have not had CPR yet, you will, and probably before you head to your first clinical day. Vertebral column, 24 vertebrae, sacrum, coccyx, divided into 5 regions. I already covered those actually. We talked about cervical, thoracic, lumbar, sacrum, and coccyx. And there's a picture of it. That's the entire spinal cord. It seems as though so many of our patients have difficulty with their lumbar vertebrae. That may have something to do with the obesity issue in our country. I'm sure you're aware we've got, so many patients that are far overweight, and the weight is pulling down on that region right there. But we do have so many patients with lumbar pain. The tailbone, the sacrum, and the coccyx, if you fracture that thing, it's a very painful thing to recover from. I had quite a few patients who did that. My wife Terry actually did that and did finally, completely recover from it. In the cervical spine, I'd like to just make mention of cervical spine injuries. If we have an injury to the neck at just the wrong level, it may affect the patient's breathing, their ability to breathe. So that is a very serious situation. One thing we have to be careful of with airway management is if there is a head neck injury, we don't want to do that traditional head tilt chin lift that you would do in CPR and that you would do for intubation. We have to do it with the head in a neutral position because if there's a fracture in those cervical vertebrae, we certainly don't want to make that situation worse. So just a heads up about that. Cervical vertebrae C1 through 7. C1 is called the atlas, C2 is called the axis, and then the rest are just called cervical vertebrae. Very important because that's where the nerves come out to go down to the diaphragm and support breathing. We use a T for the thoracic vertebrae. There's 1 through 12. I have an injury myself at T10 from weightlifting when I was playing football, and not the greatest weightlifting technique. I don't think we had quite as much understanding or coaching at the time. We were trying to just get big muscles and play good football. And so I do have an injury there from weightlifting, and I feel it sometimes with the weather. But I guess I'm lucky because it never had to be surgically repaired. You can see it on X-ray though. At the points at which the ribs connect the vertebrae are called costovertebral joints. These are cartilaginous joints. Movement does occur the third through seventh costal cartilages, which connect to the lateral body of the sternum. And then we do have those floating ribs that we mentioned earlier. So just trying to give you a good understanding of the bones, and we'll talk about the muscles here. Lumbar, there are just 5 of those, but they seem to cause more trouble than other uh, vertebrae. I guess when you're doing heavy lifting, they probably have a bigger role. That might also be part of the problem. And then you've got the sacrum, which connects to the iliac bones, the crest or the wings of the pelvis. RTs don't get involved very much with the pelvic girdle, I'd have to say. We really don't do too much down in that area, but there's a look at the pelvis. You see the sacrum and how it connects to the pelvic girdle bones. That's what it's actually called, the pelvic girdle. Um, Coxal bone, ilium. In sports, when you have a hip pointer, it's the iliac crest, which has taken the impact, and those are pretty painful. Pelvic girdle, sacrum, coccyx, collectively referred to as the pelvis. They make up the basin-shaped group of bones that connect the legs to the trunk and body, allow for hip flexion and movement, support the intestines, urinary bladder, other organs. Yeah. When you're sitting on your ischiums. The ischiums are the bones that we pretty much sit on. And the one that you feel at the side is the iliac crest, the ilium. Okay, I think those are the main points you need there. Lowest portion of the spine is the coccyx or the tailbone. It's formed from the fusion of 4 very small vertebrae. If an individual leans back in a chair, the pressure on the coccyx is increased. Leaning forward decreases the pressure. That's why you might find yourself moving around in your chair to get comfortable from time to time. I certainly do. The vertebrae of the sacrum and coccyx are unfused in young people, but they begin to fuse and all come together, usually by the late teens or early 20s. There are vertebral discs. Now, when you've had a pinched disc or heard maybe a family member or a friend has had one, this is a very painful thing where the disc is now being pinched out of its normal space and often compressing a nerve. So when those discs are not doing their job, it's going to be a painful situation. It may also affect function, in various ways. So you don't have to know a lot about that, but just that there are these discs that we're surely hoping will stay in place. Sometimes they don't. Yeah. There's a jelly-like substance there. That's a good way to describe it, which does a great job of cushioning as we move about. That's a great system that nature has for us. But because it's so soft, I guess you could say, it does get pinched easily and could bulge out The end plates bulge out laterally. Um, and that only happens with injury or aging, what you might call uh, huh, can't think of the word, but they just become more rigid, less flexible as the patient ages and may have trouble. Normal curve is an S-shaped curve that just provides a good balance, like shock absorbers. That's a great way to describe that. To facilitate this, the cervical and lumbar regions have a concave curve. Now, there should not be a side to side curve. We're talking about a front to back, anterior to posterior curve. If there is a side to side curve, that's scoliosis. And we will talk to you in other courses about kyphoscoliosis as a medical condition that we have to deal with. And uh, we're actually going to introduce it here, but it'll come up in the disease course. Kyphosis is a forward curve. The natural curve is about 20 to 45 degrees in the thoracic spine. But if it goes above 50, we say that is kyphosis. And, a lot of elderly women have this situation. I bet you've seen this, where they're sort of humped forward, you might say, or bent forward. Um, it can happen to anyone at any age, however, but it does seem to be more common in elderly females, sometimes connected to osteoporosis, the softening of bones. So that's kyphosis. Scoliosis is the side to side curve, and that can take either a C shape or an S shape, but does interfere with the patient's functioning, can be very painful. Both these can limit chest wall expansion. I might mention that if you have the two together, which we call kyphoscoliosis, that patient is likely to have a restrictive breathing defect, and can be significant. Here is a picture of kyphosis and a picture of scoliosis, which can happen together. Yeah. Blunt trauma can result in broken ribs, sternal fracture, bruise, injury to the heart and lung tissues. Sometimes, if there's a severe impact to the chest wall, the heart will be affected, and you will get fluid building up between the heart and the pericardial sac. That is called cardiac tamponade. Cardiac tamponade, and that can be very serious. I think I'll just type that up for you so that you will have that. That's fluid, maybe blood, in the sac around the heart and does need to be treated. There's a procedure called a cardiac window, pericardial window, where we do that. Yeah. Yep. People who have a broken rib will splint. Most assuredly, they do. Ribs really hurt when they're broken. Pretty much anything with the chest really hurts. So the patient will be coming in holding that area, trying not to breathe with that area. Splinting is what that's called, and you'll come to recognize that as a sign that the ribs are injured. Then we do the chest X-ray. Flail chest, you definitely need to understand. We've got 3 or more ribs broken in 2 or more places. Let me type that up for you. 3 or more ribs broken in 2 or more places. Not quite sure what happened there. 3 or more ribs broken in 2 or more places is flail chest, and very serious, has to be dealt with. Many times this patient winds up on a ventilator, and we use PEEP to help stabilize those ribs. You'll learn all about PEEP. It's positive end expiratory pressure. But there we go. That's flail chest. You do need to know about that. Oh, that's what happened. We moved to a different slide. But flail chest is 3 or more ribs broken in 2 or more places. They have to be adjacent ribs. They have to be next to each other. 3 or more ribs broken in 2 or more places. There we go. That will make a very good test question, I would say. 3 or more ribs broken in 2 or more places. Sometimes we get paradoxical movement of the chest, which means it moves in abnormal directions. One example there would be in flail chest, as the patient breathes in, The chest should move out, but it might actually suck in the area of the flailing. Pulmonary contusion is a bruise to the lung. That can be a serious situation, typically 24 to 48 hours after trauma. Um, Treatment is supportive. Large contusions may affect breathing function, may take a while for the patient to recover from a lung bruise. We had a football player, a prominent football player that had a lung bruise that took him out for several games here a couple of years ago. Can't name him for you right now, sorry. Several muscles work together to cause breathing. Now, the diaphragm is intended to do the great majority of this work, but there are other muscles that do get involved, and you'll see these called accessory muscles. I actually put that here because everything below the diaphragm there is called accessory muscles, and that's the whole list. Intercostals, transverse thoracis, scalene, pectoralis, trapezius, sternocleidomastoid, that's the strap muscle in the neck. So all of those can be involved, and that can be a sign of distress. If the patient is using a lot of accessory muscles, that could very well mean that they are in respiratory distress. Normal, quiet breathing, mostly done with the diaphragm. So there's a very good picture of the muscles that get involved in breathing. The strap muscles in the neck, sternocleidomastoid, the scalenes, which connect to the ribs to the neck, external intercostals between the ribs, pectoralis minor and major, and then internal intercostals and the serratus anterior. Those are all muscles you'll see uh, in a patient who is in respiratory distress, um, breathing with their accessory muscles. Kind of surprised that the publisher didn't include that word here, but you now know it, accessory muscles. The diaphragm is a dome-shaped muscle that forms the floor of the thoracic cavity. And what happens is the diaphragm drops down every time you breathe, and that creates a vacuum, a small vacuum that causes air to move into the chest. So it's a beautiful, simple design that you don't even have to think about as you're breathing. You're just not even really having to concentrate on this happening. It just happens. It's amazing, really. Yeah. It's connected in the front and the back, in the sides. The esophagus and the aorta have to go through the diaphragm. Sometimes that causes trouble. You may have heard of a hiatal hernia, which is a portion of the stomach that actually moves up into the chest. And when you take pediatrics, you're going to learn about congenital diaphragmatic hernia, which is where a large portion of the intestines are actually in the baby's chest. They moved up through the diaphragm where they did not belong, and that's a serious situation that has to be dealt with very quickly. Central tendon of the diaphragm is directly below the pericardium. Um, it has three divisions or leaflets, but they should all move down together. It is the dividing point between the left and right hemidiaphragm. Hey, a little uh, kind of bonus to throw in for you here. On X-ray, the right diaphragm is always a little bit higher than the left. The right hemidiaphragm is always a little bit higher than the left. Would anybody happen to know why that is? There's something on the right that's not on the left that makes the right hemidiaphragm. I'll let you think about that for a second before I give you the answer. It's the liver. The liver, because it's a solid and large organ, pushes that diaphragm up just a little bit more than the stomach, which is on the other side. So there you go. Right hemidiaphragm should be higher. The right is elevated, innervated by the right phrenic nerve and the lower intercostal nerves. Left hemidiaphragm by the phrenic. I want to make sure that word phrenic gets into your vocabulary. Phrenic is very important. Phrenic nerve on both sides. We have now a diaphragmatic pacemaker, which is connected to the phrenic nerves and can actually cause the patient to breathe even if the signal is not coming down from their brain. let's say they had a serious neck injury and they're no longer able to breathe on their own, they can breathe with the diaphragmatic pacemaker. Remarkable. I actually have one of those that was donated to my program, and I will show you. It's quite remarkable, actually. Intercostal muscles, three thin layers of muscular and tendinous fibers, 11 sets of intercostal muscles. The external intercostal muscles are involved in inspiration. The external intercostals are involved in inspiration. The internal intercostals are involved in expiration. See if you can keep that straight. Appreciate it. Transversus thoracis group includes the innermost intercostal muscles. There are also some subcostal muscles below the ribs and transversus thoracis muscle. All of these are accessory muscles of breathing. During normal quiet breathing, these are not yet generally used. Now, I was watching the Olympics here the last time we had the big every 4 year event, and at the end of the 100 meter, every runner was using their intercostal muscles. Every runner was using their accessory muscles to breathe because after that kind of effort, you are going to be using every muscle you've got to breathe. But during normal quiet breathing, we and our patients do not. Scalene muscles, scalenus anterior, medius, and posterior, located on either side of the lateral neck. They flex and rotate the neck, but they can also be used for breathing. And then the strap muscles, the sternocleidomastoid muscles on the sides of the neck, they form that strap that's easy to see in some patients, not so easy in others. But they can be involved in breathing. At the end of that 100 meter race that I was talking about, every runner was breathing with their neck muscles because they had exerted maximum effort. The pecs you're already familiar with. We do the bench press and also those butterflies on the universal gym to build pecs. And the trapezius are the triangled muscles in the back. Bodybuilders love the trapezius because it creates that V shape that is considered a successful bodybuilding. But they're all these muscles are involved in breathing. We've got two movements. We've got the bucket handle motion, bucket handle, just like a bucket handle. Just envision how a bucket handle moves. And then you've also got a pump handle movement. That one's front to back, and they work together to move air in and out of the chest. This whole thing about nature, and our breathing is just a miracle to me. I don't think any of this stuff is an accident. Nature knows what she is doing. Um, we just try to support that. That's what we do. Pump handle and bucket handle. One is sort of side to side, one is sort of front to back. But the two together get the breathing done. Abdominal muscles are considered accessory muscles of exhalation, pretty much. The six-pack muscles. Those are definitely accessory muscles of exhalation that are not kicked in normally when you're just quiet breathing, but they can certainly kick in a hurry if you need to blow out fast, like doing a pulmonary function test or blowing out the candles on your birthday cake. And there's a picture. External obliques, internal obliques. I think there are actually four sets of abdominal muscles. Rectus abdominis. Rectus just means straight. You'll see that term many times in medicine. So rectus means straight down the belly. And yes, there we go, six-pack abs. I love it. They made the connection. And accessory muscles of breathing draw the abdomen inward, pushing the air out. External obliques, yep, they're also involved. I'm not spending a lot of time on these slides because you don't need to know a lot of detail here. They're just all the belly muscles are involved in exhalation. Exhalation. That's what you might say on a test would be, when are the abdominal muscles kicked in? The answer is during exhalation, not inhalation. Transverse abdominal. There are all these different belly muscle groups. One thing I've noticed is at times when I have trained well and my belly is in really strong condition, my back's better. That's because the muscles of the abdomen support your spine, and your spine does better when your belly is stronger. Yeah. So the diaphragm drops, and normally it only drops about 1 to 2.5 centimeters in order for us to breathe. Yeah. During deep breathing, you can go 3.6 to 9.2, but that's only when we make a conscious effort to take a deep breath. So normally the diaphragm only moves a very short distance um, and uses very little energy to breathe. Passive exhalation is what normally happens, and we don't have to put in a lot of effort to that, but we have that ability to kick it in, and to breathe out much faster. Here's the accessory muscle list right there. We already mentioned them, but I'll just go over them one more time with you. Inspiration, the internal and external intercostals, the scalenes, pectoralis, trapezius, and sternocleidomastoid, which is the strap muscle. The exhalation, let's hit that so you can tell what the difference is. And then the exhalation, those are internal intercostals, internal and external abdominis, transverse abdominis, and rectus abdominis. There you go. A congenital diaphragmatic hernia can be a very serious situation. Here's the problem. When the intestines are developing inside the chest instead of the abdomen, the lung that is supposed to be growing there doesn't get a chance to fully develop. So that is a very serious situation. We pull the intestines down, that's the easy part, but then we've got this underdeveloped lung that we have to work with. And we have some ways to help with that. Hiatal hernia, situation that can happen at any age, but that's where a portion of the stomach is through the diaphragm into the chest. It's going to cause a lot of acid reflux, and it's going to be a very uncomfortable thing. Sometimes needs to be surgically repaired. Other times we can control it with just medication. Acquired diaphragmatic hernia is something that I've never dealt with. They say blunt trauma as in a car accident. Okay, I've never seen that. Paralysis of the diaphragm can happen for a lot of reasons, and that's obviously terrible because then the patient cannot breathe on their own. Um, Here's ALS, that's Lou Gehrig's disease, amyotrophic lateral sclerosis. That's one example. Multiple sclerosis, muscular dystrophy, conditions like Guillain-Barré and myasthenia gravis. All those things can, interfere with the ability of the diaphragm to contract. Work of breathing. Normally, your work of breathing is very low. It's quiet. It's easy to breathe, but it's not that way for all of our patients. And that's a sad thing. Yeah. But we can do things to help decrease the work of breathing. We can open up the airways. We can clear out the secretions. We can assist the breathing if we need to with something like BiPAP. There are lots of things that respiratory therapists do to decrease the work of breathing. And in the worst cases, we breathe for the patient. We can just take over and breathe for them. So you'll learn a lot about that as we move through the training. Respiratory failure is when you either have too little oxygen or too much carbon dioxide, um, and that needs to be dealt with immediately. So respiratory failure is measured by the blood gases. You're going to learn about the CO2, the pH, and the PaO2, and we won't go into all that right now. Respiratory rest is where the patient stops breathing completely, and you will see that soon. Yep. It will be you doing the bagging at the code. Your first code is something you'll always remember. I still remember mine, and I was the guy bagging. The patient did survive. Yeah. Intercostal retractions. When these things happen, retractions, that tells you that there is extra distress, too much work of breathing. It can be intercostal, meaning between the ribs. It can be subcostal, below the ribs, substernal, below the sternum, suprasternal at the top of the sternum, but always retraction. You notice that that word is in all of these because that's what tells you the patient is having distress, increased work of breathing. Okay, in a normal individual, the skeletal structure protects the heart and lungs. Alterations like kyphosis or scoliosis can definitely interfere with that. Injury to the skeletal muscles can result in deeper injuries to lungs and heart. Pulmonary or cardiac contusion, all that can happen. You will see all of it in your career. The muscles of the thoracic cavity play a very important role in breathing, and we do have accessory muscles that can help when there is a need for more than the diaphragm can do. Now, we gave you already the list of the inspiratory muscles and the expiratory muscles. I won't repeat that. Work of breathing, how much work is the patient actually doing to breathe? And then there are conditions that actually interfere with the diaphragm's ability to work at all. Those would be things like ALS, Lou Gehrig's disease, multiple sclerosis, muscular dystrophy, neuropathic disease, and Guillain-Barré. That was a lot in one chapter. I hope that you enjoyed that and learned some useful things there. Just a reminder, I'm preparing your midterm review sheet, and I will have that in your hands quickly. The midterm is due by the end of week 4, so not next week. You've got a good bit of time to prepare for that. I do need to find the case study. Let's see if we can get back here. Nope, that's the previous case study. So we'll drop that down. Those are the slides. Chapter 5 case study. Here we go. 27-year-old male brought to the ED by emergency medical services. That's the squad. Mountain biking in a nearby state park. Was thrown from his bike, hitting some rocks. Was found by hikers partially covered in mud and semi-conscious, so not completely alert, with the bike lying approximately 150 yards away. The time of his accident is not known. It is also not known if he lost complete consciousness for any period of time. He appears to be in pain, breathing rapidly. Assessment in the ED reveals temperature 37.3. That's just a tiny fever, not much at all. Heart rate 124. That says he's under stress. Respiratory rate 36, too fast. Generally, adults breathing faster than 35 will not be able to sustain that. Blood pressure, high, 156 over 116. That also says stress. Oh, pulse ox, 72%. This young person, this young man should have a pulse ox of 95, 96, 97. His is 72. So there is a serious problem going on with his oxygenation. Lab report, white cells 6.2, that's okay. Red cells 5.6, hemoglobin 16, that's good. Hematocrit 40.7. Okay. Mean cell volume, mean cell hemoglobin. So you're going to have to look up a bunch of things here to understand what all these mean. Platelets 378. Okay. So there's a lot of CBC data there you're going to need to study in order to understand this case. Information provided by the hikers who found the biker suggests he may have been thrown against some rocks. What sorts of injuries may result from blunt trauma to the thoracic cavity from such an occurrence? Just talked about that. During the physical examination, the provider notes an abrasion to the left anterior chest, left front, and that a portion of the patient's rib cage is moving paradoxically from the rest of the chest wall. Chest x-ray confirms the third through sixth ribs on the left side have broken and are separated from the rest of the chest cage. There's a name for that. You may remember it from just a few minutes ago. The man is being prepared for emergency surgical stabilization of the chest wall, placed on 100% oxygen, and will be intubated by anesthesia in the operating room. You note that he is still breathing shallowly and appears to be splinting on his left sides. What complications can result from splinting if this is left untreated? I think that's a great case. That is real world stuff that you will deal with soon in the emergency room, and I'm glad that we've got a case like this one. So there you go. We have covered chapter 5. We've covered case study 5, and I think you're in good shape for now. Enjoy the rest of I hope that you're enjoying the rest of your Labor Day weekend and not just working the whole time. I hope you get some some break out of it. And otherwise, I will see you in class. See you in class soon.